Cool.
So we are here at the DYF T1D Adult Retreat with Dr. Calvin Wu, who's an endocrinologist at Steady Health, who's going to be talking about the transition from pediatric care to adult care and how Steady Health can help. Take it over, Calvin.
All right, so I'm going to share a screen. All right, and let me just put it out there right now. Obviously, if there's any questions, we're happy to just stop and answer those as we go and so forth. So, but yeah, so really excited today to talk about transitioning to pediatric to adult care. For me, I've actually trained in internal medicine and pediatrics and through residency, so I've seen the full spectrum of from kids to adults. I've seen this transition done well. I've seen it done poorly. And so for me, it's definitely kind of a, something I really want to improve in that sense. It's something that's near and dear to me. So yeah, really excited to get into this topic. So for a quick overview though of the talk and so forth, let's start talking a little bit about diabetes and emerging adulthood. Once we define that, we can talk about some of the challenges that make this transition so difficult. That said, we can certainly talk about some tips to make that as successful as possible. And finally, kind of introduce Steady Health if you're not familiar to kind of see how that we may be able to help with that transition as well. All right. So let's start with the diabetes. And for better or for worse, unfortunately, this is an issue that's becoming more of an issue, I should say, and that's because there's more and more people with type 1 diabetes. There's an estimate that right now that there's about 15,000 youth diagnosed per year with type 1, and even for type 2, there's about 3,700 as well. So the latest stats from the CDC, just from a report this year, actually showed that the number of people who have, adults and children who have type 1 diabetes is about 1.6 million actually. And that's in fact a 30% increase from 2017, interestingly enough. This is also affecting minorities more and more. We've always thought of this as affecting potentially more Caucasian populations, etc. But actually, in the recent stats show that there's a 20% rise in African Americans and Hispanics. Asian and Pacific Islanders are actually not that far behind as well, and at 19%. So this is affecting a greater population in general. Worldwide, in fact, type 1 diabetes in children and young adults has doubled in the past 25 years. And expected to double yet again in the next 15 and 20 years. So again, this is an issue that we really need to come to grips with in that sense and manage well. On the other side of things, the epidemic of childhood obesity has really led to an increase in type 2 diabetes as well. So that also adds to numbers of people who are dealing with diabetes through this transition. So let me define real quickly this concept of emerging adulthood. It's often defined as from the ages of 18 to 30, so starting right after high school and kind of moving on. This is clearly a period of exploration. Unfortunately, it's also a period that's fraught with anxiety and uncertainty. As you get more freedom from parental supervision and rules, that also means you have to take on more responsibilities. So there's it can be very daunting, and there's this transition you have to kind of grapple with yourself as well. So there is a developmental theorist actually that kind of subdivided emerging adulthood into two categories here. So there's an early phase, which again, right after high school, age 18 to 24. Then in this group, people are often transitioning away from the parental home in many ways, like emotionally, for instance, from a job standpoint, academically, for instance, as well, and geographically too. They may be moving away from the home in that sense. As well, they're dealing with a lot of competing priorities, college, school, jobs, for instance, new relationships and otherwise. So, unfortunately, healthcare can often become a low priority relative to everything else that's going on. Certainly in this group too, there's a desire for independence, but also a fear of it, right? You've developed some skills to cope and manage things and so forth, but you're not completely confident yet that you can manage on your own. And lastly, for some, there's a feeling of invulnerability and a tendency to reject adult control, and that can make this transition more difficult because you may be less receptive to outside input. But as you grow older and you move on to the second phase from age 25 to 30, this is where you're starting to take on more intimate long-term relationships, taking on long-term jobs, for instance, and you're developing a mature sense of identity. You're assuming more adult-like roles in society. You become more and more aware of the long-term importance of better glucose control. And that may be relevant with the relationships you form too. You want to be around to be there with your partner, your friends, etc. You become typically more receptive to improving your self-care behavior. And a lot of times this is where these critical lifelong patterns for behavior are being established. So again, a really critical window throughout this. So a lot is going on during this phase. So there's definitely, there's a lot going on from here, much less the care side. So what's challenging here, of course, is that there's a stark contrast between what's pediatric care and what's adult care, right? And I want to be clear, this is somewhat of a generality of sorts, but that said, these are kind of widely held kind of opinions and truths, I should say, about how we deliver care towards pediatric populations and adult populations too. On the pediatric side, we tend to be more family focused. The visits are often with the youth and with the parents and so forth. There's significant parental involvement in all decision making. It's also very more likely to deliver care at the appropriate level of development. As kids obviously have varying levels of emotional, maturity, cognitive ability, etc. So there's a gradual kind of encouragement to teach and help people understand the aspects of self-care and gradually transitioning that care over. So it's always, delivering it at their level, in other words. Finally, there's an emphasis on management approaches that fit diabetes into the lifestyle of the child and family. It's less about, everything revolves around diabetes. It's more about how do we fit this into your lifestyle, make it reasonable as well too. Unfortunately, when you move to transition to adult care and so forth, there's a shift. And many times it becomes very focused on the individual, right? And in fact, when you become an adult, you start to have to sign waivers for anyone else to even see your medical information, right? That's the first step, in fact, in many cases. And there's a general sense that you can counsel, you can give information, but at the end of the day, the patient has to be the one to make the decisions about their behavior and their management and so forth. So it definitely requires more autonomy and independence with management. For better or for worse, visits are often shorter, and they're very focused on medical problems. It's blood pressure, it's cholesterol, it's these things, and that's all they really talk about. There's much less about, what is your lifestyle situation, how you're developmentally handling all this transition otherwise. For better or for worse too, there's a lot of more emphasis on the risk for long-term complications. Unfortunately, I hear all too often with some of the patients I get that, all they hear about is complications. And last but not least, there tends to be fewer interdisciplinary resources. Whereas around pediatric care, for instance, there often is a team, right? A CDE, nutritionist, endocrinologist. There's a team that's available to provide support. Whereas adults, you tend to be on your own for the most part. So those resources can vary widely between different institutions. So given those stark contrasts, it's not surprising that this is often an abrupt transition. Again, you're transferring this burden of diabetes management gradually from the parent to youth throughout this entire period, childhood and adolescence. So it's teaching them how to manage their diabetes on their own. It's making medical appointments on their own eventually. It's learning to finance their own healthcare, right? Unfortunately, the transition from pediatrics to adults is very abrupt, right? It's like you basically one day you leave your pediatric provider, next day you're in your adult, right? And unfortunately, this is a process that's very abrupt and unsettling. 58% in one survey actually reported a negative transition experience. More than half changed their adult provider at least once. And throughout all of this, many felt that their glucose control was actually better than it really was. So there's no doubt in my mind that this transition could be done better, but also the transition should be more gradual in many ways. So we'll talk about that shortly. But interestingly, in one survey that looked at what emerging adults would want for their diabetes care and so forth, these were some of the things they brought up, evening hours, flexible clinics, for instance, a longer visit as initial meeting with the adult provider, having a chance to really get to know them and not just kind of be rushed through another 20, 30-minute visit. Special clinic times, just focus just on young adults and teens and so forth up to the age of 30. A written information about what the transfer process looks like and how the new physician will kind of work with them. There's certainly a lot around continuity of contact, so being able to get in touch with your providers and get the feedback that you need, for instance. And finally, clinicians who want to try to integrate their life circumstances into their recommendations. Again, something that's very, very highlighted in pediatrics, but in adults, it's less so, unfortunately. So with that, let me move on to talking about some of the challenges to transitional care. We've identified some of them, but let's kind of crystallize around what those are. A lot of it's actually, I think, inadequate preparation, right? And if you look at some of the studies, unfortunately, there's a lot of poor communication between families and providers too from the get-go. So only half of parents actually ever discuss their child's changing needs with a physician. And of those that did discuss the changing needs, only 30 to 42% discussed the whole concept of transitioning to an adult provider. So again, there's, people aren't really ready for this in that sense. On the other side, from the healthcare provider standpoint, unfortunately, we don't talk well either, actually, from between pediatrics and adults. There's a general lack of transition protocols. Only 1 in 3 adult providers reviewed the pediatric records, which is terrible. And then only 1 in 10 even reported receiving a summary for emergent adults with type 1 diabetes. So these are terrible, terrible stats. And you can see how this, just from the first step is kind of, gone awry, essentially. So I put here a list of some of the challenges, and we'll dive into some of these shortly and so forth. But there's, for better or for worse, there's limited evidence on what the best approach to this transition process is. There's a number of models out there, and we can talk briefly about them on one of the later slides and so forth. But there's no good evidence on what the best way to move forward is actually. As we talked about, there's fundamental differences in how healthcare delivery occurs in pediatric and adult populations. There's a lack of well-defined criteria for determining, are you ready for this transition? Like maybe it shouldn't be really, well, as soon as you're 18, for instance, you need to transition over. Maybe there needs to be more conversation around, are you ready for that transition? Sadly, gaps and uncertainties in healthcare. For instance, a lot of times we can stay on our parents' insurance for up to age 26, and then you're on your own, right? And so being able to finance that, diabetes is, for better or for worse, is an expensive disease, right? And so not being able to have the insurance and having to worry about your insulin, for instance, otherwise really is not something you should be worried about, right? But it unfortunately is. There's, as we talked about, there's differences in learning styles, but also in practice styles. Pediatric physicians tend to practice very differently than adults. And so when you meet with 2 different providers, from the end of pediatric care to adult care and so forth, you can hear very different recommendations. It can be very jarring and hard to understand how does this connect really. And that kind of highlights really that there's deficiencies in how we train our healthcare professionals. A lot of this, unfortunately, has been put on pediatrics, which is to say, oh, it's the pediatrician's job to do this and so forth. But there really needs to be more crosstalk, right? The adult providers, too, need to be part of this conversation so that this process can be as smooth as possible. And finally, of course, there's definitely difficulty leaving a long-standing relationship with pediatric clinicians. When you've been diagnosed in an early age and so forth, you have a connection with these providers you've seen year after year and so forth. So to give that up all of a sudden it's very difficult, right? And I've heard many actually that will stay into their mid-20s, even late 20s and so forth with their pediatric endocrinologist for this reason. And unfortunately, this translates into a number of outcomes. When you look at poor glucose control, only 32% of those that were aged type 1 with type 1 between ages of 13 to 18, and only 18% of those above actually achieved the ADA recommended A1C targets. And if you compare this data to some similar data for adults, it's 56%, right, that achieve an A1C target of less than 7%. So much lower, unfortunately. And of the proportion of youth that actually have type 1 or type 2 with an A1C above 9.5%, teenagers feature prominently here. And one in every 4 patients that are 12 and above had such elevated A1C levels, so quite a few. This is actually data coming from the type 1 exchange registry, and you can see here the average A1C by age. And of course, which fits with everything we just talked about earlier, the highest A1C here was at 9.2% in those who are 19. So again, a challenging transition already for many reasons. Many are then subsequently lost to follow-up. There was a survey that was done of people with diabetes that transferred from a pediatric to an adult clinic. 31% of those adolescents had a lapse of over 6 months between their last pediatric visit and their first adult visit, with 11% actually lost to follow-up entirely, which is terrible. And then, although 90% transitioned to adult services by the age of 17, only 61% regularly attended adult care programs 2 years after the transfer. So again, retention rates are not great either. This is also a time that, as we're looking about long-term complications, and actually, I shouldn't say just long-term, actually, even acute complications. This is a period that, in some studies, seem to suggest higher rates of hypoglycemia in those who are in this group. Overnight hypoglycemia is seen as up to 8.8% of nights, with 23% of those actually lasting 2 hours or longer. So that's very significant, obviously, very risky as well. And in some other studies, the 19 to 21 age group with type 1 diabetes had the highest rates of hospitalization, diabetes-specific bed days, and emergency visits in California, actually. So this is data coming from the state here. Meanwhile, fortunately, you may know that complications take years to develop, fortunately. And so therefore, the rates of these complications are low in those who are adolescents, But unfortunately, there's evidence of early microvascular complications, those early signs, those early small vessel disease and so forth. So we often, for instance, check a urine protein test, for instance, to see if there's any leakage in the urine. There's 10% of adolescents actually that start to show some sign of that. When you consider peripheral neuropathy, which can present in many ways, numbness, tingling, pain, even subtle decrease in sensitivity, 20% actually by one study. So again, these are signs of something kind of brewing that we're not being able to control. And obviously, the better we can make this transition, the better we have a chance of kind of really tackling these issues. Not to mention mental health, right? Psychosocial issues and so forth. There's a lot of stressors around diabetes itself that can make it very difficult to kind of stay on track with medical care in general. As you're interacting with people more and more, there's uncomfortable interactions about explaining what diabetes is, what am I doing, etc., and people that don't understand what this disease entails. There's feelings of guilt or anxiety when your numbers don't look as good as you're told they should be, for instance. And certainly worrying about the future, thinking about, gosh, these complications, what if I get them, is this the rest of my life really? And so this factors, heavily, and in this whole idea of diabetes distress really has really come to kind of the limelight lately, and it really should, because it's a huge aspect of the disease. I would argue just as important as the numbers. Depressive symptoms, 15 to 35% of emerging adults actually suffer from some degree of this. And anxiety, which is the most common psychiatric condition in general, certainly can present in diabetes, and it's often tied to hypoglycemia, right? Whether it's anxious about hypoglycemia, whether it's hypoglycemia manifesting as anxiety, for instance, those two are very intimately tied, actually. And in young women with diabetes, unfortunately, it affects men too, but in women especially, eating disorders are up to 2.4 times more common as well. On the topic of sexual and reproductive health issues, there definitely needs to be more reproductive planning to avoid unplanned pregnancies, maximize kind of the outcomes of these pregnancies as well. When you look at contraceptive use, it's lower compared to those without diabetes, 61 versus 73%. And among teens, actually, 13 to 19, only 16% were using birth control. And among those who were sexually active, in fact, only a third of them had never used birth control ever. And that's important because if you think about it too, less than a quarter of women who are 16 to 20 with diabetes were even aware that that this matters, that the maternal and for the baby, the risks involved with the pregnancy, and the need for good control actually throughout the pregnancy to ensure that the baby is healthy and otherwise. This is important information that may or may not be conveyed, unfortunately. Alcohol, smoking, drugs, this is often the age that you're learning, you're becoming more and more exposed to these things. Alcohol, we know, can certainly complicate glucose management, obviously, with both highs and lows, and it's certainly a known risk factor for severe hypoglycemia after the fact. Cigarette smoking, we know that can increase heart disease risk, and it also increases the risk for kind of the kidney complications as well early on. Drug abuse, high-risk behaviors in general, and combined with the risk for low blood sugars, can have lots of implications for complications, but also when you're driving, right? You're learning to drive at this time as well. So yeah, as you can see, and that just touches the tip of the iceberg, I'd say. There's a lot more that I'm not diving into, but this is a very challenging transition. So we really need to make sure that everything is done as much as possible to make this as smooth as possible. So with that, I want to kind of share some of those tips for making that transition as smooth. So the goal overall, again, is really trying to make sure our care is uninterrupted, comprehensive, and accessible. We want to be able to maintain glucose control throughout, and the ultimate goal, of course, is to prevent the possible complications coming up. So really, the optimal approach should really borrow from the pediatric book in some ways, match a young person's life circumstances and readiness to become an active participant in his or her own care. And that's going to involve a lot of early preparation, patient education, and open conversation between all the stakeholders. So this slide's a little busy, but let me distill it down to the fact that there was a federal agency actually that looked at this healthcare transition and kind of defined kind of 6 core elements that this process should include, and it has some responsibility for the pediatric provider as well as the adult provider. And maybe it's better illustrated in this kind of simplified kind of timeline of sorts. It's the idea that early on, even at 12, 14, for instance, there should be a discussion of what is the transition policy, preparing them years in ahead of time to know that this is something that's coming up, for instance. then tracking their progress through this. As they move from age 14 to 18, for instance, see how well they're ready for transition, see how well they're adapting to self-care and taking on their own management in that case. Transitioning readiness, really assessing their skills. And then as they kind of really get closer and closer to transition, developing a very clear plan, how to make that healthcare transition happen, including a medical summary, which is critical. Then you actually transfer to adult-centered care. You should integrate into adult practice, and there needs to be closed-loop feedback, right? Which is to say that once they go to the adult provider, there needs to be a communication with the pediatric provider as well, confirming that the process went smoothly, being clear about what other ways they can improve for the next time as well. So I think in terms of the specifics, I would say definitely this should be done in collaboration with everyone involved, particularly the young adult and the family, to prepare for this transition. Right, pediatric providers again should begin to prepare youths for that transition. Early adolescence is ideal, so age 14 is suggested, for instance, but it certainly should happen at least a year before the transition. In terms of what that should involve, it should be a written plan that includes what services are needed, who will provide them, how will they be financed. And there should be a clear plan for assessing and improving upon self-management skills and independence to navigate that healthcare. This should be reviewed and updated regularly so that when there is a transition that happens and so forth, you're ready from every dimension. And then really critical to have this up-to-date medical summary, a written kind of notebook or whatever that basically describes everything, the medical history, their degree of self-care skills, their complications, medications, and also emergency care plan, right? Just what if something happens, what should I do? And kind of having a game plan for that is critical, really. Back when we were in MedPeds clinics and so forth, we actually had the binder that people would have, and we would help them, put papers into that so that it's very clear that if you go anywhere, you carry this with you, so that when you transition care, that they'll know what's going on. Part of this is also identifying early on who are the adult providers that can accept and partner with the young adult. These are people, especially in the context of type 1 diabetes, should be well versed in how to do intensive diabetes management. It can't be someone who's seeing every 6 months, dilly-dallying on just some numbers and so forth. They need to understand complexity, and this is a complex disease. I just put here a quick link, by the way, to Endocrine Society. They actually have some good links for both the provider and for patients. So if you ever are interested, I encourage you to check that out. It has some worksheets and otherwise that you can print out and provide that you could fill out yourself as well as bring to your provider to make sure they cover all their bases. And lastly, let me talk about a couple models for transition to care. Certainly have the traditional unstructured transfer, which is say, good luck, essentially. And we know, as we talked about earlier, how well that works, unfortunately. But there's certainly the concept of transferring to a young adult clinic, right? So within a pediatric hospital, for instance, they can have an older age group, for instance, that they will specifically use to transfer young adults first before they move on to adult care. There's a rising concept of transition coordinators, so people who can kind of make sure this process goes smoothly throughout, and help you schedule visits, but also reschedule missed visits as well. So really helping to as a backup, really making sure that those visits are actually scheduled and things actually follow through. There's education programs as well. So some of these include like workshops aimed at preparing transition, and maybe even monthly visits for the first 3 to 6 months when that transition is happening. This is actually, the last one is what this concept of guided transfer, and this is a friend of mine actually at Stanford who's done this. He is MedPeds trained as well, and he actually will initiate care in the familiar pediatric setting. So see them in the pediatric clinic, then when they both feel ready, transition them to his clinic as well. So that unfortunately isn't always really available, but that's certainly an ideal kind of transfer in that case too. Last but not least, let me just pose that as well that CGM by itself too may also help to make this transition a little easier. This was a study actually that looked at introducing some teenagers and young adults to CGM and so forth. And we saw earlier, by the way, that typically the A1C goes up during this time frame, right? But the simple act of instituting CGM here actually led to a reduction in A1C of 4.4% as well. So this is kind of helping to raise awareness of the numbers, raise awareness of ongoing management and so forth. So just a simple act of CGM alone, I should say, may be helpful in this transition too. Cool. Any questions up till now, by the way? No? Okay.
I have a question.
Yeah, of course.
And you might be talking about it with study too, but I'm just curious for folks who have now past, like they're now in adult care, but are still a young adult, are there, and maybe they did not have all these tools and a great transition, are there things that they can be doing now to kind of almost backtrack to help make it smoother from here on out? Or is it now like they're kind of stuck?
No, I think there are definitely things that can be done. I mean, obviously, when it's many years after the fact, it becomes harder because in some ways you've developed a relationship already with the adult provider. They kind of have their set of paths that they've already decided on. But I think particularly even a year or 2 years after the fact, for instance, connecting with the pediatrician, the pediatric provider, for instance, and trying to getting a sense of how that transition went, and also making sure all the relevant records are transferred over. And maybe even just having a frank discussion of how that transition went may be helpful, because again, a lot of times, provider to provider, they can have a conversation as well to kind of convey their concerns. For better or for worse, the adult provider needs to care actually what the pediatric provider thinks, because again, if they don't think they're a good fit in general, they'll stop sending patients their way as well, right? So it's in their interest too to kind of make sure that everything goes smoothly. So
great.
yeah,
So never too late to circle back.
No, I don't think so. I don't think so. And again, I think it's open communication is a critical piece here. It's being open and honest about what you think is deficient. Figuring out what those pieces are and letting everyone talk about it, really. So that is maybe not just in for your case as well, but also for the greater good of the transition, I think.
Great, thank you.
Yeah, absolutely. So last but not least, I kind of want to touch a little bit about study health, kind of introduce it, because I don't think a lot of people know about it yet. But in this sense, I'm not suggesting this is the ideal by any means, but I think some of our unique features here may be really helpful for this transition. So STEADY, what is it? We are a team of clinicians, engineers, care coordinators that really want to change the conversation around how diabetes care is delivered. We don't think the way it works right now with a quarterly visit and A1C and so forth just doesn't really cut it. So we are the nation's first fully digital, full service diabetes clinic, currently serving members throughout California, but very shortly in Washington too, actually. So knowing that you live in Seattle, for instance, this could be a good fit for you to consider. So in that sense, we are, to be clear, first of all, we are an endocrinology clinic. So we can do everything that entails, prescriptions, labs, paperwork, etc. But we also go above and beyond, which is to say that we rely heavily on CGM to give us like an up-to-date picture of your glucose numbers and so forth, and combine that with software and telemedicine to make it as seamless, connected, and personal as possible. So maybe some sense of that. We definitely recognize that diabetes is complicated and highly personal. So we actually have our members, for instance, log their activities during the day, their meals, etc., so that we can get a good glimpse at what their lifestyle and their management looks like. And when we have that and so forth, then we can combine that with their CGM curves and understand a little bit more about kind of what's going on and so forth. And then we can then discuss that openly to figure out what the next steps are. Our goal is really about identifying actionable insights, so things that you can actually do from this and so forth, then setting some personal goals around that and figuring out what specific strategies you can do to get there. And then we'll help you with that throughout as well. So for some of the things we built into our software, for instance, when you log a meal, for instance, you can then see the corresponding CGM curve there below this actually. So you can actually learn, and our hope is to use CGM to be that tool that helps you kind of iterate and learn from your experiences. So you can go back and say that, oh, the last time I had this particular meal, what did my CGM, what did my glucose curves look like? How much should I give then? How can I improve it for the next time, for instance? And our job, by the way, is just to put these tools in your hands, but also to talk about that openly and use this as something that we discuss at quarterly visits, for instance, or do messaging as well. The other critical thing that we want to put in here is continuous care, really. We don't believe diabetes can be managed on a monthly, three-month basis, really. Things come up in between. And so in that sense, we have messaging built into our platform as well. So you can basically text us anytime there's an issue. We have access again to your data, so we can actually look at it and make an informed decision on the spot and to discuss with you, kind of your concerns and otherwise. So in that sense, we probably interact with people. Probably one estimate is actually 20 times more than a typical pediatric provider, I should say, around diabetes. Because again, we're not here just for the visit. We're here actually everywhere in between. And when we see numbers that are potentially lower than you want them to be, we can intervene too, actually. Last but not least, we're also in touch on a regular basis with these notifications. So there's this concept of, we call it right now intervention threshold, which is the idea if your time and range drops below a certain range, we contact you. And then if you're achieving your goals too, we'll be there to congratulate you. On a monthly basis, then we'll also provide a report like this. So you can see a week-to-week breakdown of like, what is your time in range and what is your average glucose is, how does this fit your goals overall that you've kind of decided on? And we continue to, at visits, kind of define, are those the right goals? Are those the right projects? So it can help you really move the ball forward in terms of what you want from diabetes care. We're definitely keen on technology. We've come a long way in the last couple of years even with technology and so forth, and we're really excited to kind of share and figure out where technology can help you most. So obviously we're very familiar with CGMs, with smart pens, inhaled insulin, but also all the insulin pumps and so forth. We're happy to support all the full line of automated insulin delivery systems, including Loop, for instance. So our members really can run the full gamut. And our job, I think, is to really figure out what is the right tool for you, and help you kind of use it to the full advantage, really. Just to kind of highlight that we have a really outstanding CDCES as well, and her job is a lot of times to do one-on-one coaching sessions after we've kind of identified what areas we can work on. And we're also building a growing education library as well to kind of support that and so forth. So you would have access to this to kind of add to things, and we're constantly curating more material to this. Just to give you a sense of the insights that we can develop and so forth. This is actual patient data, by the way. And what we can see here is that when you actually log something, you can see, we can click an icon and actually see what you actually ate. We can see what you ate and so forth, and knowing with your carb ratio, we can see how you respond to this. And over time, we can then help you figure out that maybe that isn't the right carb ratio, for instance. Maybe 12, but maybe 9 looks a lot better, and you can see the difference in curves across here. But having this data available makes this a much more comprehensive experience for everyone involved, because again, the truth is, CGM at the end of the day, without supporting information, is a bunch of squiggles, really, right? But when you have a bigger picture of what they're actually eating, what they're actually doing, and so forth, then you have a much better, you can make much more informed decisions, and particularly you can drive behavior change and appropriate therapy changes as well. Another example. This is a young woman in her 30s and so forth. She is on an insulin pump, and she's always really struggled with kind of meals and so forth. This is dinner. And so what happens is every time she boluses for dinner, she basically always plummets initially. So she's very sensitive up front. So this is an example of her trying an extended bolus, 50% up front with 50% over 3 hours. You can see, unfortunately, her blood sugar still dropped there. So one of the projects for her was actually kind of tackling this step by step and so forth. So we actually did multiple iterations of this. And eventually we got to this. And I can tell you right now, I would never know to do this. But what worked perfectly for her is 20% up front with 80% over 5 hours. And this has been a strategy that she can replicate now for dinners in that case. And that's how we learn and iterate on this kind of concept, is the fact that we have the information available to us. We can analyze it together, discuss it, and plan for the future. And in that sense, really improve on each iteration in that case. So this is what excites us. We like the data. We like the fact that we can actually make a meaningful difference in these cases. And yeah, I think in that sense, we're excited to really offer a different option besides the traditional experience around diabetes care. So in summary, really, I think that the key points to really think about is with Steady, you get on-demand access to diabetes experts over video and messaging. You get personal advice and coaching based on your daily glucose levels, your nutrition, and the lifestyle. You get continuous care between visits. We're not it's not just the visit itself, but there's reports, there's notifications, there's messaging all throughout. And finally, the visits are simple. You just simply book in our app and so forth. And a lot of visits are in fact available within the same week, many times actually within the same day. And you take it wherever you are, whether you're in the office, in the clinic, or at your home and so forth. So if you're interested, go ahead and click and find this link we're at Steady Health, and you can contact us by phone or fax and so forth. But in that sense too, I really want to highlight that we're a different option here. And in that case too, like my personal background as internal medicine and pediatrics, again, I really am invested in making this experience as good as possible. And so in that sense too, I'm personally very comfortable taking on anyone 14 or older, essentially, with type 1 diabetes, and being part of that process transitioning over. In fact, I would probably propose, in fact, that you continue seeing the pediatric provider while you see me, and we basically overlap with each other and talk about that transition before it actually happens.
How does that concept of continuous care work with insurance? Like, do you get billed every time you text message?
Great question. So right now, so full transparency, we do have a membership fee. So it's $60 a month as it stands right now. And that includes all messaging and any work right now with our CDCES, actually. So visits are billed to insurance. So that's kind of the traditional experience. And obviously medications go with your insurance as well. The $60 then allows access to the platform that lets us kind of communicate directly. So that would cover all of that. We're working on it right now, by the way, actually, to incorporate more and more of that to the, so more of it, less of it comes into the membership fee and more of it goes towards insurance, by the way. So our hope is actually to drive that cost down for membership fee down actually in the near future. So stay tuned. And yeah, we're just to be clear too, we're going to be launching in Washington very shortly in the next couple of weeks in that sense. So for instance, Seattle, we would be available there certainly.
Do you ever, is it always fully online, or do you ever see people in person? Like for
Great question. We started as a kind of a hybrid of the two. We have a clinical rotation, I should say, in downtown San Francisco. We actually made the decision to go completely virtual in January though, before COVID hit actually. And the goal there was actually to spread our reach throughout California and to particularly help areas I think that don't have great access to endocrinology who could use resources like ours in that case. And for like we definitely have a lot of uptake within the kind of techie area around where we are in that sense. But no, certainly we have people that span the whole state of California, and that's to us is very exciting because we can help these people when people really have no one to turn to. The next visit for endo is often 3-4 months away, whereas we can see them within a week.
Is like the reason you can't go outside of California, is it just like legal concerns, or?
Yeah, it's state licensure at that sense. So we have 2 endocrinologists right now. The other is Dr. Sushma Reddy, and so she is actually licensed in Washington, whereas I'm licensed in California at the moment. But yeah,
I could see this being really useful for like transition stuff, just because when I transitioned to adult care, I also transitioned to like a completely new state. And so that was very jarring as well.
Definitely.
Not having anything to do with like pediatric to adult.
Of course. Yeah.
But obviously there's legal stuff in the way for that.
Yeah, unfortunately. I mean, for better or for worse, I think the current pandemic has actually kind of, caused kind of these changes to happen very, very quickly. Things that we would have expected to take years are happening within months in that sense. So it is exciting to see that. But that said, I think the state licensure stuff is really meant to kind of protect everyone involved and so forth. And I think they are a little behind the times in some ways. But for now, at least, we're kind of bound by the state laws in that case. So hence the restrictions. So the main thing I'd say is having an address in Washington or California. Obviously, when people travel, we don't care about those boundaries, but we want to be on the right side of the law, let's say. So. Cool. Yeah. So that's all I have essentially. But I'm happy to take any questions. I can give you my personal email, by the way. Calvin, CALVIN @steady.health. If you have any questions, feel free to reach out there. And otherwise, our website is a great way to kind of really understand what we do. So feel free to check us out.
Thank you so much. That was awesome. Super informative.
Absolutely. My pleasure.
I really appreciate this. I feel like you validated a lot of the struggles I've had in transitioning to adult care over the past couple of years. So
it's a very tough process, and kudos to you for having made some transition. And we'd be happy to, if there's any resources we can provide to help you make that transition a little smooth or otherwise, let us know. So
great.
Thank you.
Of course. Yeah. Take care.
Bye.
Bye.